All right, a few more things I want to tell you about. So prevalence, we've mentioned this in class before. The latest prevalence rates are 1 in 68. 1 in 68 children being diagnosed with autism. That's the 2014 statistic from the Centers for Disease Control. A 30% increase from 2012, where the number was 1 in 88. In 2007, the number was 1 in 150. Why the rise? We don't exactly know. People speculate that sort of the changes in the diagnosis, better screening, as we get more informed, we're able to identify more cases more readily. But other people think that it is more than just issues related to detection and diagnosis, that there is something going on, maybe environmentally, genetically, but that research is still budding. 4 to 5 times more boys will develop autism, so that number is 1 in 42 for boys, 1 in 189 for females. 3/4, somewhere between 50% and 3/4 of children diagnosed with autism also have IDD, intellectual developmental disorder. So that's a big number. And that functional combination of IDD and autism leads to the greatest impairment. So 30% of this 3/4 will have mild to moderate intellectual developmental disorder, in terms of intellectual disabilities. 30% will be mild in terms of that. 45% will have severe to profound intellectual deficits. On 1/2 of those with autism and intellectual developmental disorder lack functional speech, right? So that combination of having autism and IDD, 50% of those children will be essentially nonverbal, lack functional speech. They're using things like communication boards and maybe having interventions like that. White children are more likely to develop autism than Black or Hispanic children. There are geographic differences noted within the United States that are pretty fascinating, where the number in Alabama for children diagnosed with autism would be 1 in 175. That's the lowest prevalence in the United States is seen in Alabama. So think of it relative to that 1 in 68. So 1 in 68 nationally, 1 in 175 in Alabama. In New Jersey, 1 in 45 children will be diagnosed with autism, and 1 in 28 boys in New Jersey. 1 in 28 boys diagnosed with autism. 1 in 133 girls in New Jersey. So you can Google this. There's some interesting articles trying to speculate why those New Jersey numbers are so high. New Jersey is known for having very excellent and well-developed screening and diagnostic systems. They also have very good special ed programs. So there's some people who suggest that people who maybe have a child diagnosed with autism move to New Jersey to get those services. But a lot of other people say no, 85% of these children diagnosed with autism in New Jersey were born and raised in New Jersey. They haven't just been transported in. So still really not sure what accounts for those numbers in New Jersey, but probably is related to some degree to some advanced screening. This word is blurred out. They actually have a registry where they keep close track of children with autism in the state. Alrighty. 2 more, folks. The developmental course. So we typically will see symptoms emerging by 12 to 24 months, and those symptoms peak at 2 to 4 years. The symptoms referring to the things we just talked about with the DSM criteria. We see a lot of heterogeneity, meaning many pathways, such huge variety in how children with autism will present. Everything from their language to their social communication, their social interaction patterns, their repetitive behaviors, great variation there. 15 to 30% display regression. This is interesting because about 10 years ago when we were talking about autism, it was defined that there would be normal development. The child was developing completely normally, and then there would abruptly be a change and they would regress, and suddenly they would lose all the words they used to have, for example, or suddenly they'd lose the sparkle in their eye or something. That has changed, I would say. So now 15 to 30% display regression. But the question is that following truly typical development? There's been some interesting work looking back at home videos and just in general more closely following what it looks like in the first year for a child who ultimately gets an autism diagnosis. Are they truly developing normally? And then there's a sudden shift in regression, or is more likely the case that there were some signs, they just were not picked up on in that first year because you didn't know this diagnosis was coming. So that's sort of an interesting line of research and a shift in our thinking about autism, not necessarily so much seeing this all of a sudden drastic change. When will there be improvement? So we're talking about the developmental course and multiple pathways here. You're most likely to experience improvement in the social and communication areas. So the best chance of improvement is for those with higher functioning at diagnosis. So in terms of your levels of severity, if you're at a level 1 in severity at the time of diagnosis, greater chance that you will continue to improve throughout your lifespan, especially in the areas of social and communication. The least sort of rosy picture, or the least chance of improvement, will be for those children who have that multiple diagnosis of both IDD and autism. They show the lowest chance of improvement throughout the lifespan. The repetitive behavior pathways are the most stable and the most problematic, right? So there's some graphs in your book. I'm not going to quiz you on the details of that, but where people will show some improvement on their trajectories of communication and those social domains, the repetitive behaviors are very hard to extinguish. So we see those high and consistent in most cases of autism. I wrote here possible asset because some individuals with autism are able to take those hyper-focus areas and turn that into some sort of a career or a hobby, maybe something, that can even pay the bills. So if they're really excelling in one particular focus area. Okay, and lastly, I'm just going to say a couple words about etiology. We'll talk more about this in class as well. So, in other words, these prevalence rates are so high, what's causing autism? Well, it's considered to be a highly genetic disorder, so high heritability. The proportion of risk attributable to genetic factors has been reported to be as high as 90%. What do we mean by those genetic factors? Well, one model takes a polygenic look, which means that there are interactions among several genes. It's not just one gene that certainly causes autism, but interactions among a number of gene sequences. That would be consistent with the high association with IDD, multiple genes involved. Another genetic approach is focusing on these rare gene mutations and sort of tracking those. That seems to be especially the case with advanced paternal age. So when the father is old at the time of conception, that is linked to a certain set of rare gene mutations. Possibly some prenatal complications, so before the baby is born, some biological complications. But we have ruled out the association of vaccines with autism. That's a controversy that we'll talk a little bit more about in class. In terms of environmental risk factors, advanced parental age, not just paternal, but advanced parental age is a risk factor, low birth weight of the baby, and fetal exposure to valproate. So valproate is a drug that's used to treat epilepsy. So in women who are epileptic and who are pregnant, who might take valproate, and they might need to, fetal exposure to that particular drug is known to increase the risk factor. More to come in class. We'll talk about brain anomalies and how the brain structures are different in children with autism, and brain development and how that changes for children with autism. We'll talk about how it's assessed, and then we'll talk about successful interventions and treatment. Bye-bye.